absorptive disorder, they can present with diarrhea and malnutrition manifestation. So my topic will cover diarrhea, malnutrition, malabsorption. It will be an interactive session, so I may ask people to share and to come with certain things. The objective of my talk is to define the diarrhea and what we mean by chronic diarrhea, then the clinical approach of malnutrition and malabsorption, then how we can manage those patients. First of all, if we are saying diarrhea, we can divide it either an subjective way or objective way. Subjective way is by asking the parent, how is the stool pattern? Is there increased frequency, validity, amount? And this is easy by asking the parent. But in pediatric, especially neonate, we can miss diarrhea because diarrhea in the neonate, it can be almost resemble urine. So the mother, she may think whatever passed is urine rather than diarrhea. So the objective way of defining diarrhea is when we have an increased stool output more than 10 gram per kg per day or an absolute amount more than 200 gram. In neonate, we can do that one by putting urine catheter. So whatever collected in the bag is urine, and whatever now in the diaper and we can measure it comes from the stool. So once we have a diarrhea, we ask ourselves, is this acute diarrhea or chronic diarrhea? This is very important because if it's acute diarrhea, we are talking about certain characteristic, mainly infection related, and the differential diagnosis of acute diarrhea is beyond the scope of my talk today. Acute diarrhea, it's normally less than 2 weeks, and it is mainly infection related, and the management strategy of those patients is dehydration management. Prevent dehydration, be sure that the patient had good hydration status. Whereas in chronic diarrhea or persistent diarrhea, if it's more than 2 weeks, and those have different differential diagnosis and different management strategies. Is my voice is clear?
Yes, sir.
Okay. So when we have a diarrhea is more than 14 days, this is an chronic. And we are covering in my talk today the chronic diarrhea. Acute diarrhea, it is general pediatric presentation. And as I mentioned, gastroenteritis is the typical disease which can lead to acute diarrhea. When we have chronic diarrhea, we are asking ourselves, this diarrhea, it can be classified into a different way, and this classification, it will help us to know the pathogenesis and the offensive and the cause. Normally, we can classify the chronic diarrhea either osmotic versus secretory, or it can be secondary to inflammation or inflammatory process, or abnormal motility and malabsorption. Anyone can give me a way to differentiate osmotic versus secretory?
Fasting.
Fasting, you are absolutely right. So if you can look in the table here, the mechanism of osmotic diarrhea, you will have unabsorbed solute by which your gut cannot handle. So the offensive things which lead to the diarrhea is the presence of unabsorbed food in your gut. So if you put this patient in fasting, the osmotic diarrhea, it will decrease significantly because the offensive solute is not there. Whereas in the secretory diarrhea, you will continue to have diarrhea regardless of your fasting state. And the typical example of osmotic diarrhea is malabsorptive disorder, like carbohydrate malabsorption, where secretory diarrhea, the commonest example is the congenital chloride diarrhea. And it can be secondary to exudative or inflammatory process by which they will have a defective colonic absorption. And the typical example is inflammatory bowel disease. And the last thing is motility disorder, which is very rare in pediatric population, by which you will have decreased contact time. And this can be seen in irritable bowel syndrome or diabetic neuropathy. In secretory diarrhea, you will have continuous diarrhea regardless of the fasting state, and the diarrhea will decrease only under one condition. Anyone can come when we will have secretory diarrhea, by which the diarrhea decrease? Just think in your body as a ball. If you have severe dehydration, so you will not have any further fluid comings because you are dry. So always if you have a secretory diarrhea or congenital, like congenital chloride diarrhea, and the patient comes because and you ask the mother and the diarrhea said it's improving, this is not good sign. That means he is already dehydrated. So always osmotic diarrhea improve with fasting, and this can be used as a diagnostic criteria rather than management, and secretory diarrhea will continue. So this is what we just mentioned before. Secretory diarrhea, little change with fasting, and normally the stool pH is natural or normal, and we can measure the stool osmotic gap. In secretory diarrhea, it will be normal, less than 50. And we can measure the stool osmotic gap according to the equation which you find, 290, which is the normal osmolality of your serum, minus 2 multiplication of normal, minus the stool content of potassium and sodium. And the commonest example, as we said, congenital chloride diarrhea. Where is the osmotic diarrhea? We said the diarrhea will improve with the fasting, and the osmotic gap here will be more than 150 because of the higher osmotic or osmolar load in your gut. And normally, because this is mainly secondary to malabsorption, in carbohydrate malabsorption, they will have acidy stool, so the stool pH will be less than 5. And the commonest example of osmotic diarrhea is malabsorption secondary to celiac disease or cystic fibrosis. Normally, we should know the normal stool electrolyte, because by measuring the stool electrolyte, we can measure the osmotic gap, and we can differentiate between secretory diarrhea and osmotic diarrhea. And normally the dominant cation is the potassium, it's 90 millimole, and followed by sodium 40 millimole, then chloride and bicarb. And also the stool electrolyte, it can be a diagnostic clue of certain disorder, like in congenital chloride diarrhea and congenital sodium diarrhea. Those normal stool electrolytes will be flipped. In congenital sodium diarrhea, the sodium will be more than 150 millimole and more than the sum of the rest of the salt. In congenital chloride diarrhea, it's again the same. The chloride will be more than 150 millimole and more than the sum of the rest of your electrolyte. Any question regarding diarrhea, chronic diarrhea, pathogenesis, and how we can approach those classification? Hello?
All clear, doctor.
Okay. Then we will talk just a little bit about malnutrition, because those malnutrition, the chronic diarrhea and malabsorption, they can present with malnutrition. Normally, pediatric population, they are in a growing stage. So if they have anything interfere with their growth, mainly the malnutrition, it can interfere with the growth of a child. And the growing child, he needs both macro and micronutrient. And the main cause of malnutrition worldwide is non-organic disease, because of unfortunate people, they didn't have that diet because of hunger and unbalanced diet. In 5 to 10%, it can be secondary to a disease process, which we need to find in order to help them in their management. And normally, how we can look for malnutrition, we can look for signs and symptoms of micro and micronutrient. Macronutrient, if we said macro, we are talking about big things like carbohydrate, fat, protein, and this is very important for energy and growth and activity. And we can look for those one in the patient growth parameter, his weight, his height, and we will come to that one in the growth chart. So Macronutrient, it's important for growth, energies, and activity, whereas the micronutrient is the micronutrient, things like vitamins, zinc, selenium, blah, 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 which is important for certain enzyme activity and metabolism of your body. And most of those micronutrients, it can be observed, and there is a well-known disease process leading to that. Like in vitamin D, we will have, in case of vitamin D deficiency, rickets, and we know that the vitamin D is important for bone. For vitamin A, it's important for vision, so it can lead to poor vision and night blindness. And again, vitamin B1, it is important for muscles, and it can lead to manifestation called beriberi. So it's important for you to know those micronutrients and its manifestation and its affecting metabolism and the disease status, which can lead to iron, it can lead to anemia, and this is well known. So again, malnutrition, it's not look only for the micronutrient and the weight, always look for the micronutrition manifestation, so you can look for pallor, anemias, blah, blah, blah. So this is very important, because once you have a patient with malabsorption and the gut cannot handle the normal absorption capacity, this will lead to malnutrition. So when we said malabsorption, it is secondary to insufficient maldigestion. Maldigestion, it's intraliminal enzyme digestion, or malabsorption, by which you will have decreased absorption site, or there is an inflammation with the absorption site. How they can present? Normally, those kids present with two cardinal manifestations: chronic diarrhea and failure to thrive. You can see the child in the picture to the right. Once you have a patient who had chronic diarrhea more than 2 weeks and failure to thrive, always those red flag of malabsorption. In the same time, look for sign of malnutrition. They can have edema, anemias, abdominal distension, decreased muscle tones. Those kids need help. Once you have them, we should really work them, because as we said earlier, kids, they are in growing stage. This will interfere with their growth. How we can, once you have a patient who had a chronic diarrhea and failure to thrive, normally we plot them in the growth chart. And this is the growth chart. The lower, you can see my arrow, or it's not?
Yes, doctor, we do.
Okay. This one is the weight, whereas the upper one is the height. And this is 3 different growth chart. The one in the left, if you can see this unfortunate child, first of all, he is a boy, because it's now, it's red, it's blue. Normally for a girl, we put pink, growth chart color. So if you can look to the weight, it is decreasing and crossing the centile. In the same time, it's affecting not only the weight and height. If it's affecting parallelly the weight and height, think an endocrine disorder like growth hormone. If you have a patient and the growth decline mainly in weight, and it's not affecting the height, maybe in later stage it can affecting the height, think in malabsorption. If both weight and height is going up, there is no decline, however, it is almost in the borderline, this we call it stunted or proportionate growth failure. And this proportionate or stunted, it's maybe secondary to genetics or constitutional. So most of those one, really, if you see the patient, he's a small, he's not wasted, he's not malnourished. So this is what we can see in the growth chart. Physically, we can see them as the picture. The problem, I am trying to share it. Okay, I hope it is will work. Yeah, maybe. This is the one in the left normal. There is one in the middle wasted, the one in the right stunted. So which one is malnourished? Anyone can come with suggestion?
The one in the middle.
The one in the middle. He is wasted. How you know he is wasted if you didn't see the picture? How you know from the number below that this is the wasted child?
He has normal height but low weight.
So which one you will take? The weight for age centile or weight for height centile or height for age centile?
We would take the height for age and then the weight for the height.
It's mainly he is wasted because weight for height is low. You see that one in the middle? If you come to the stunted and the wasted one, both of them, their weight and for age is below the 70, whereas the one in the middle, weight for height is low. So he is wasted because his weight for height is low. So always you should take weight for height centile in order to know if this patient is wasted or not. Clear?
Yes, doctor.
So this is the wasted child. If you have a patient with chronic diarrhea, failure to thrive, and he's wasted, you will think on malabsorption, as we said. What's the differential diagnosis of malabsorption? Anyone can come with some differential? Tons of differential. You can see it. So it's difficult to have and memorize those differentials. So we should classify the malabsorptive disorder into some sort of classification in order to come with a limited differential. How we can do it? We can do it in different way and modalities. We can do it, is this having a neonatal diarrhea or not? Because of the onset, it comes immediately after birth. We know most likely this patient have congenital or transport defect, and we will have limited differential. Neonatal diarrhea can be secondary to congenital chloride diarrhea, sodium diarrhea, glucose galactose malabsorption, acrodermatitis enteropathica, which is zinc deficiency, or ultrastructural defect like macrovillus inclusion disease, tufting enteropathies, intractable diarrhea of infancy, or immune deficiency disorder. So we will have a limited differential because this unfortunate child developed diarrhea in the neonatal period. So one of the clues to classify the malabsorption and to come with limited differential diagnosis is the age of onset of diarrhea. The other clues is this diarrhea comes or increase with introduction of certain food. We know the celiac disease manifestation start only after introduction of gluten-containing food, after introduction of mixed diet. So you will never put celiac disease in a differential diagnosis of a patient who is 2 months old, never exposed to gluten-containing food. Certain disorder, they will have their manifestation with exposure of certain food, by which you will know the differential diagnosis according to that offensive cause of diarrhea. Glucose galactose malabsorption, they can present in neonate, whatever milk type you will give, they will not tolerate it because glucose and galactose and most of the milk is lactose containing carbohydrate. So we should give them a specific type of formula called galactamine 19, which is a fructose based formula. It's normal milk formula. However, the carbohydrate content of this formula is fructose. So this will be very important as a clue to know the differential, and it's also important in the management. We can classify it according to the cause and the pathology of the diarrhea, which we mentioned it earlier. Is it osmotic? Is it secretory? And we can classify it according to the pathophysiology of the content itself. Is it carbohydrate malabsorption, or is it protein malabsorption, or fat malabsorption? And this is good because we want to know how we are absorbing normal food. If we come to carbohydrate, how we can absorb carbohydrate? Anyone can help me?
Using the brush border enzymes in the GIT.
Okay, for sure. We need an
Starts in
intact brush,
starts-
but
no.
you are absolutely right. So it's always for carbohydrate, the final digestion process in the brush border, but the initial stage is start with in the mouth with the presence of
Amylase.
salivary amylase. And the salivary amylase, normally, it can break the starch into 1 and 6 oligosaccharide and 1 4 oligosaccharide. So salivary amylase will break the starch into sugar oligosaccharide, and then after the salivary and the mouth, we need. Do we need the stomach?
Pancreatic amylase to break down the stuff.
Do we need the stomach? Not that much.
No.
We need the pancreatic amylase in the duodenum. So we have the salivary amylase in the mouth. We also pancreatic amylase in the duodenum. And we will need the brush border disaccharidases, which one of your colleagues mentioned. And the disaccharidases there in the brush border is isomaltase, which will break the 1,6 oligosaccharide into glucose, and the maltase will break 1,4 oligosaccharide into glucose. Lactase will break the lactose into glucose and galactose. Saccharase will break the sucrose into glucose and fructose. And then we will end with simple sugar. We'll absorb it in the enterocyte into the circulation. So we need a healthy, intact brush border. If there is disease process there, it can lead to carbohydrate malabsorption. So which disease can lead to carbohydrate malabsorption? If you have pancreatic enzyme deficiency, the typical example is cystic fibrosis, Schwarzman-Diamond syndrome, or isolated amylase deficiency. Any disease process which break the brush border secondary to whatever disease, it can lead to an acquired carbohydrate malabsorption. So if you have celiac disease, allergy, cow milk allergy, infection, inflammatory bowel disease, bacterial overgrowth, all those can lead to an inflammatory process breaking your brush border and leading to carbohydrate malabsorption because of insufficient disaccharidases enzyme activity within your brush border. Last one is the glucose galactose malabsorption and sucrase isomaltase deficiency. Those is present normally in the neonate. The glucose galactose is common in our society. It's not common. We are seeing it here more than other country because of the consanguinity and familial relative marriage, and normally those can be treated by, as we mentioned, giving them fructose-based formula. If you give them those one, they will not absorb it. You will end with malabsorbed disaccharadases, and this can lead to osmotic force driving water, leading to watery diarrhea in your gut. And is it osmotic diarrhea or secretory diarrhea? So, osmotic diarrhea, because the offensive is unabsorbed nutrient, unabsorbed solute in your gut. Any question regarding carbohydrate malabsorption?
No, doctor.
Now for protein, just I will give you some cartoon regarding how we can absorb a protein. Normally we will have the pepsinogen, which activated into pepsin in your stomach, and this will break the protein into amino acid, but it will not break it completely. Some of the protein will reach it the duodenum intact, and we need also the pancreatic proteases, which further break the protein into di and tripeptide. And we have also something called peptidase within the brush border, which can break the large peptide into amino acid and di and tripeptide. We have a specific carrier protein for the amino acid into the enterocyte, into the circulation, and we have another specific carrier protein for di and tripeptide, which can hydrolyze further within the enterocyte by the cytoplasmic peptidases into single amino acid. And you will end mainly with amino acid into your circulation with a small amount of di and tripeptide. This is the normal protein absorption. Which disease process can interfere with this normal? First one is, again, pancreatic enzyme deficiency, and the commonest and the typical example, cystic fibrosis, Schwarzman-Diamond syndromes, and trypsinogen deficiency. Again, we need a healthy, intact mucosa. So whatever disease process interfere with this normal villi, it will lead to a condition called protein-losing enteropathies. And the commonest example, again, post-infection, cow milk allergy, celiac disease, inflammatory process, allergies, all those can lead to a disease manifestation because you will have destruction in your peptidases and those carrier protein within your enterocyte. There is other specific genetic disorder can lead to amino acid absorption because of the carrier protein defect, and there is no need for you to know about it. And the commonest and the typical example, and this is followed by our geneticists, is the heart-valve disease, interkinase deficiency, and Lewis syndromes. And if you stuck with those one, you will have a manifestation of protein-losing enteropathies. This is simple cartoon of normal protein absorption and the disease process which can interfere with the protein malabsorption. Any question regarding the protein, guys?
No, doctor.
Lipids, what we need for lipids? Which organ?
We need the pancreas and the liver.
So we need the pancreas. You are absolutely right. We need the lipase in the pancreas, which will break the triglyceride into free fatty acid and monoglyceride. What else other than pancreas?
The liver.
You are absolutely right. We need the liver because we will have emulsification process by presence of bile salt, which make the muscle formation, which lead to adherent of these fat droplets to the enterocyte. So we need good healthy pancreas, good healthy liver in order to have this adherent of and the muscle formation. Then we will need also intact healthy mucosa, but once we have the muscle formation adhere into the enterocyte, we will have absorption or intake of this free fatty acid and monoglyceride, and we will have ultra process of fat chemical absorption within enterocyte by presence of lipoprotein and chylomicron in order for this to be absorbed into where? Lymphatic. To the lacteoles or the lymphatic into thoracic tract into the systemic circulation. So any disease process intact with this normal lipid physiological process, it can lead to fat malabsorption. So if we can take it one by one, if we have lipase deficiency, like in cystic fibrosis, Schwarzman-Diamond, person disease is another entity and they have manifestation of lipase deficiencies, or we have liver disorder, cholestasis, bile acid malabsorption, cirrhotic liver, because it will prevent the emulsification process and the muscle formation. Again, if you have damage of your villi, this adherence of process of the muscles in the enterocytes, which will be interfere. Other disorder, you remember when we said there is an ultrastructural process within the enterocyte, it can lead to fat malabsorption like an beta lipoproteinemia or chylomicron retention cyst. And also you should have healthy lymphatic. So if you have patient who had lymphangiectasia, lymphomas, this will interfere with the fat malabsorption. Can we bypass all those process? Any patient with lipid malabsorption, if we want to bypass those process, we can give the patient MCT based formula. We call it medium chain triglyceride, because medium chain triglyceride, it goes into portal circulation rather than goes into lymphatic circulation. So most of those patients with liver disorder or lymphangiectasia, we put them in MCT rich milk formula like Portagine, Monogene. You will hear those formulas names, but it's more or less they are dominant in MCT base oil formula within their content. Any question? So if we can summarize it, lipids, protein, carbohydrate. If you have pancreatic enzyme, it's interfere actually with absorption of all those micronutrients, the lipids, the protein, carbohydrate. If you have mucosal damage, it can interfere actually with all. If you have lymphatic and lymphangiectasia, it may be mainly the lipids content. So depending where is the injury, and it will lead to, and if it's intraliminal enzyme digestion, it's mainly because of this enzyme, and the management is enzyme replacement. Clear? Any question? I hope it's make it easier.
Everything's clear, doctor. Thank you so much.
Okay. Now, if you have a patient with a chronic diarrhea, it depends, because which is common, it's depend in your location. Normally, if you are in the West, you will find celiac disease, cow milk is the commonest. If you are in third world countries, normally post gastroenteritis and post infection is the commonest. Here in our countries, we can see celiac disease, but we can see congenital chloride diarrhea, congenital sodium diarrhea, glucose galactose malabsorption more than the West. So depending where is your practice, you may see different entity of disorder in your practice depending the location of your practice. How we can investigate those patients? If you have a patient who had chronic diarrhea, failure to thrive, this child need help. He need workup in order to come with a diagnosis, because the diagnosis is very crucial in the management. Most of our management is pointing to the diagnosis, and every diagnosis have different model of therapies. We can start those patients have high stool output. Simple stool workup is crucial. Anyone can comes with how can stool workup help us and classify and comes with the diagnosis?
Yes, doctor.
There is the presence of blood in the stool.
Presence of blood in the stool for sure.
If there
What
were
else?
troubled electrolytes, you can tell it's a transport defect.
For sure, stool electrolytes can help us even to reach a definite diagnosis, like in congenital chloride diarrhea. What else?
We can do a culture.
Stool culture, for sure, because it can be infection, especially in immune-compromised patient. They can have a chronic infection state, which lead to malabsorption. What else?
If there was a change in the pH, you can tell there's a carbohydrate.
For sure. Stool pH and reducing substance, it indicates there is a carbohydrate malabsorption. If there is fecal fat, and we can measure even 72-hour fecal fat, which can indicate fat malabsorption, alpha-1 antitrypsin and alpha-1 antitrypsin clearance, it can help us to diagnose protein malabsorption. And again, stool electrolyte, cultures, presence of blood, the presence of bacil or eosinophil, it can give you a hint either to a definite diagnosis in culture and electrolyte, or if we are dealing with allergic conditions. So it's important to do stool culture because it can minimize your differential. Clear? Blood test is very important because you can do CBC, and always you can look in the CBC. Is this patient leukopenia? Is there is a sign of immune deficiency? Is the patient anemic? Which type of anemia? Is it macrocytic? Is it because if the patient had Baylor and anemia, he may have iron deficiency or vitamin B12 deficiency? If there is an inflammatory process, you can do ESR. Serum albumin will be low in protein-losing nephropathies. Again, liver status should be assessed, so you can do liver enzyme, and you can always check for macronutrient, which we talk about it, because those patients, they can have macronutrient deficiency. Check the vitamin D, vitamin A in the serum. We can do celiac disease screen like tissue transglutamine, which can help you identifying the diagnosis of celiac disorder. Thyroid function test, it's important because it can interfere with the motilities. And we can do immune deficiency screen because most of the immunological disorder, they can present early on with chronic colitis-like picture. Radiology, it can help in certain disorder if we are entertaining Schwarzman-Diamond syndrome, which they can have pancreatic deficiency, they can have cyclic neutropenia, and they can have skeletal dysplastic-like picture. So if you have a patient who have pancreatic malabsorption, cyclic neutropenia, and he is short, and you can do skeletal survey. Barium study is important for patient who had inflammatory bowel disease. Endoscopy, if you have a patient and you are suspecting a mucosal damage, and you remember we said we have to have an intact mucosa in order to have normal absorption. So if you have patient and you think there is a mucosal damage, we can do endoscopy, by which we can have a biopsy in order to assess the mucosa itself. Is there is atrophies, is there is an inflammation, is there is giardias, and also we can do electron microscopy, by which if there is an extrastructural defect like in tufting enteropathy and microvillus inclusion disease. We can do also enzyme testing, and we can do duodenal aspirate. Further imaging and investigation depend. If you have a patient who had diarrhea and you examine his tummy and he had abdominal mass, what do you think? So what's going on with this patient? He had abdominal mass and he had diarrhea. Do you think his problem is in the gut?
It depends on where the mass is.
Abdominal mass, large abdominal mass.
It could be
near the kidneys, above the kidneys.
Adrenal hyperplasia.
Neuroblastoma. So if neuroblastoma, it can secrete certain vasoactive intestinal peptide leading to diarrhea. So if you have abdominal mass, you may have secretory massing leading to diarrhea. Those patients, they didn't have gut anomalies. They have a tumor. So those patients, you will do CT scan, and once you confirm neuroblastoma, they need our pediatric oncology, because we are dealing with malignancy, tumor, rather than gut. So it's important not just to take history. It's important to examine the child from head to toes. Abdominal examination is a must, because you may find a sign in your abdominal examination, give you a hint of a certain disorder. It's not including all the above. If there is abdominal mass, things always in malignancy, mainly neuroblastoma. Hydrogen breath test, it's important to diagnose patient who had carbohydrate malabsorption. And what's the time now? We have time. Yes, we have 15 minutes. Chilling test, it's important because it can give us a hint why we have vitamin B12 deficiency. And we can do also, if we are suspecting immune deficiency, certain immune SA subclasses. This is how we can work up patient. We start with simple things. We go into advance in our investigation by tailoring it according to the initial finding. For us as an gastroenterologist, celiac disease, we diagnose it by presence of villus atrophy, and this is the biopsy. This is another giardias, and we can see the trophozygous. And patient with lymphangiectasia, you can find those dilated submucosal lacules. So in certain mucosal damage, we need endoscopy, but we didn't need endoscopy for any patient who had malabsorption. Clear? How we can manage patient with malabsorption?
By treating the underlying cause of it.
For sure. So always treat the underlying disease. So you should really work this child well and try to find definite diagnosis, because the management depend in the underlying disease. While you are doing your investigation, or if you come with patient who needs supportive therapy, you should really support them with corrective nutritional deficiency like iron supplement, vitamin D, but always treat the underlying disease. Because if you have patient who had celiac disease, we know those patients' mainstay of management is a gluten-free diet. If he had lactose deficiency, lactate, glucose galactose malabsorption, you put them in fructose-based formulas. If you have patient who had cow milk allergy, you give them hydrolyzed protein formulas. Patient who had intestinal lymphangiectasias or severe pancreatic insufficiency, they need MCT dietary supplement. If the patient had cystic fibrosis, the mainstay of treatment is enzyme replacement. We give them pancreatic enzyme replacement. So it's very crucial to come with the diagnosis, because your management depend on the underlying disease. There is some people, they will withhold the feeding or restrict the intake to reduce the diarrhea. This is not good practice unless you are doing it as a diagnostic tool to withhold this diet, trying special another formula to come with a diagnosis rather than management. Clear? Take home message. Main presentation of malabsorption is a chronic diarrhea. Chronic diarrhea is common. It can be secondary to post-infection, but it can be secondary to a disease process, and the management of those chronic diarrheas depend on the underlying disease and correct the nutrition deficiency. Any question?
No, doctor, everything is fine.
I have 3 cases. I need one to read this case, please.
I can read it.
Please.
2-week-old infant with chronic watery diarrhea, dehydration, not gaining weight, no fever, no blood in stool. How would you approach this problem?
So what is the important information you have in this patient to limit your differential?
The patient is only 2-week-old.
Okay, this is great. So what you will think, which disorder?
Usually I would look at malabsorption, like glucose, galactose malabsorption, lactose intolerance.
Okay.
Maybe a
And the congenital secretory defect.
Yeah, sodium chloride diarrhea.
You are absolutely right. So you will think in certain disorder which is having some congenital defect, like congenital chloride diarrhea, glucose galactose, lactose intolerance. Don't forget the ultrastructural defect like microphallus inclusion, tufting enteropathy, autoimmune enteropathies, or acrodermatitis enteropathica, which is secondary to zinc deficiency. So we have a limited differential. You should not put inflammatory bowel disease in 1-week-old. Very, very, very rare. You should not put for sure celiac disorder in those patients. Clear? Who want to read the second case? It's long. Hello? Who want to read the second case?
I can read it, doctor.
Please, proceed.
Okay, so the parents of a 14-month-old boy bring their son to your office with a 2-month history of 2 to 6 loose, non-foul smelling watery stools per day. At times, there is undigested food in the bowel movement. The parents have gone through multiple diet changes, and now the boy is only eating a low-fat, no-dairy products, lots of fruit juices, and a minimal protein diet. He has had an extensive workup, including negative stool cultures for bacteria and viruses, negative stool for ova and parasites, and no blood in the stool. How would you approach this problem?
Is there any information you need, or this is sufficient? It is almost 8 lines.
I think this is sufficient.
I disagree with you.
Maybe we should order a CBC.
No, I want you. What is missing in this information, which is very crucial for you to entertain chronic diarrhea management?
The patient's weight.
Weight. You are absolutely right. Did we mention the weight? No. So depend. Your differential will be pending. Is this chronic diarrhea leading to growth failure and failure to thrive or not? If I said there is the patient thriving well and he is normal, except he had diarrhea, are you worried? His weight is great. Are you worried?
Not so much, but still I would like to stop the diarrhea to prevent dehydration.
For sure. You are absolutely right. So first of all, presence of weight loss is a red flag. If you didn't have weight loss and the abdominal examination is normal, there is no mass, most likely you are dealing with which condition? Can be a benign condition?
Yes, maybe.
What we call it? There is something we call it toddler diarrhea, by which if the patient have or consume a lot of sugar, candies, he will reach and exceed the capacity of gut to handle. So this patient, if you can see from the history, he's consuming a lot of juices, fruits, candies. So and if there is no growth failure, most likely this patient had toddler diarrhea, and the treatment is just diet modification. On the other hand, if this patient had significant weight loss, are you worried?
Yes, absolutely.
For sure. So what will be your differential if this patient had weight loss with this scenario?
Maybe celiac disease.
For sure. Can read it. Pancreatic insufficiency. Toddler diarrhea in presence of normal weight, which we cover. But if there is significant weight loss, think in the rest of the differential. Mainly, as you said, celiac disease, pancreatic insufficiency, lymphangiectasia, lactose intolerance, infection. So again, it's the same presentation of diarrhea, but with normal weight, you will think in the certain disorder. If there is significant weight loss, you will think in malabsorption disorder. Last things, who will read the case 3, please?
Okay, I will read it, doctor.
I can.
Please.
Okay. So we have an 8-year-old boy present with 3 weeks abdominal pain, bloody diarrhea 4 times per day, with urgency, night stooling, and intermittent fever with weight loss. How would you approach this problem?
So what will be your differential? What disease you will think about? Bloody diarrhea, tenesmus, urgency, weight loss.
So inflammatory bowel diseases.
For sure, inflammatory bowel disease.
And bacterial infection.
Like salmonella, shigella, yersinia, for sure, pseudomembranous colitis, or lymphomas, or immune deficiency syndrome. So we have 3 cases, all they present with diarrhea. However, the other symptoms, which is included in the diarrhea, it's completely different. The age group is different. And in all, we have different differential diagnosis. So this is very important because once you entertain your management, you should come with differential diagnosis and the disease. By now, I am ending my presentation. Is there any question?
No, doctor.
Okay. Have a good day, guys. Bye-bye.
Thank you.
You too, doctor. Have a nice day.
Good.